Hello, I'm going to be discussing what's new with PrEP and HIV today. This is the faculty for our presentation. I'm Ethel Weld. I'm an assistant professor of medicine, pharmacology, and molecular sciences at Johns Hopkins. And Jim and Cindy will introduce themselves and follow my presentation. I have no disclosures.
So this program is provided by the North American Center for Continuing Medical Education, an HMP company, and DKB Med, and is supported by an educational grant from Gilead Sciences and Mylan. If you have any questions during the presentation, type it into the chat box on the lower left side of your screen under the faculty headshots, and the faculty will answer all questions at the end of the presentation.
The educational objectives of this presentation are to describe benefits of pre-exposure prophylaxis against HIV, determine who is eligible for PrEP, and discuss any barriers to initiating PrEP and keeping people on PrEP, assess factors that can complicate treatment, both treatment of HIV and prevention of HIV with PrEP in special populations, discuss the value of various treatment interventions that can improve adherence, and discuss some cost considerations. Here are my definition slides, so you can refer back to these at any point. Just wanted to start out initially by discussing some background on HIV in the United States. So incidence of HIV in the U.S. has slightly declined over the past 10 years. There's about 38,000 new cases. About 2/3 have a mode of transmission that's via male-to-male sexual contact, with heterosexual contact coming in second at about 16%. The graphic at the lower right shows the distribution of new cases of HIV divided by age group, and you can see that the highest age group is young adults from 26 to 34 years of age, but in second place is young children and adolescents in this age group of 13 to 24 years of age. It's important to note also that among the over 1 million people in the U.S. living with HIV, so this is prevalence, not incidence, greater than half of them are over age 50, as shown by this middle graphic. The majority, 3/4, are male, and people of color are disproportionately represented among those living with HIV in comparison to their percentage of the population. Here are displayed the U.S. Preventative Services Task Force guidelines for screening for HIV. These were updated last year. And there's a grade A recommendation to screen all adolescents and adults aged 15 to 65 years of age for HIV. People outside of that age range who are at increased risk based on appropriate screening questions should also be screened. Universal testing for all pregnant women, regardless of any circumstance, including those who present in labor or at delivery whose HIV status is not known. And then more frequent than yearly screening for those who are at increased risk. So people who inject drugs, youth, people seeking care for TB or bacterial sexually transmitted infections, and those prescribed pre-exposure prophylaxis. The interval for screening among these groups is not explicit. There's not been a recommendation for screening more than annually, but it is standard clinical practice in many clinics to do so. And really the main point of these recommendations is to routinely test. Do not only test based on perceived risk, so really integrate it into your systems. The impact of early diagnosis is significant, and even with the state of testing as it is now, significant numbers of people are identified far later in disease with more comorbidities associated with that. And people who do not even know that they have HIV account for 40% of new sexual transmissions of HIV. Once people do know their status, their risk behaviors tend to change. about 15% of people living with HIV in the U.S. do not know that they have HIV, and almost half of youth with HIV do not know that they have HIV. So, earlier testing leads to earlier diagnosis, linking people to care. The individual has a survival benefit, their partners have a benefit, and there's a transmission blocking step for the community, particularly if people living with HIV become undetectable in their viral load. So treatment as prevention is the concept that treating someone with HIV prevents that person from passing it on as long as their HIV viral load is below 200 copies per ml. And this was established by several formative studies. The PARTNERS study from the HIV Prevention Treatment Network, Prevention Trials Network, 052, showed a relative reduction of 96% in HIV transmissions with early treatment of HIV in seropositive partners who were positive and had a negative partner. The PARTNER study, the opposites attract study, several studies looked at this as well and found 0 transmissions when the positive partner had an undetectable viral load. And there's really to date not been one phylogenetically linked transmission of HIV if the positive partner's viral load is undetectable. This has led to the U=U campaign, which means undetectable equals untransmissible. This has greatly reduced stigma for individuals living with HIV who do not have to live in fear that they're going to hurt their partners. It has led to changes in WHO and DHHS guidelines and basically has been a revolutionary movement that supports treatment for all people living with HIV as soon as diagnosis is made. So this is just to support that among those living with HIV/AIDS in the U.S., a large proportion are unaware that they're infected, a large proportion are not in care, and a certain percent, 20%, are in care but not suppressed. So in terms of the partner that has transmitted HIV, those are factors that make them more likely to transmit. You don't see a dark green bar here because those who are in care and virally suppressed do not transmit. In terms of the continuum of care, people living with diagnosed and undiagnosed HIV, there are over 1 million, as I mentioned, and we have a viral suppression rate of 56%. So there's clearly a lot of room for improvement in every single step along this continuum, but the first step is to diagnose. As we know, there's been great strides and great gains in the treatment of HIV over the past 3 decades, and you can see that the mortality from HIV has declined as the uptake of antiretroviral therapy has increased. So this has been really a victory story. Lifespan among those with HIV and those without HIV is now comparable, especially if people are treated with antiretrovirals. And most people with HIV tend to die of non-AIDS-related non-AIDS-related causes, malignancies, mostly not related to HIV, co-infections, et cetera. So I want to shift right now to talking about pre-exposure prophylaxis and some of the benefits and barriers. Pre-exposure prophylaxis was established with formative trials that established the proof of concept that taking antiretrovirals, if you're not infected with HIV, can prevent you from getting HIV. And so there are now 2 medications approved for PrEP since in the 8 years since the first PrEP study was completed. There is TDF-FTC in a combination tablet, and there is TAF-FTC. TDF-FTC is approved for men and women. TAF-FTC is approved for men and transgender women, but does not have the approval for cisgender women, largely because the trials that established its efficacy did not significantly include women. But taken correctly, this can be really greater than 5% effective in preventing HIV transmission. But the first step in prescribing it is identifying people who are at risk for HIV infection, which really requires taking a thoughtful, non-judgmental, open-ended, open-minded sexual history and substance use history. It's important to note that PrEP is a program. It's not necessarily just a drug. It does not prevent other STIs, and it should be part of a comprehensive approach that's going to emphasize frequent screening of sexually transmitted infections regardless of symptoms, and education about safer sex practices, including consistent condom use, which is the best way to prevent other bacterial STIs. So when should you consider PrEP? If someone has had a recent sexually transmitted infection diagnosis or requests testing for sexually transmitted infections, reports that they have inconsistent or infrequent use of condoms, has recently had a situation where they've had to take post-exposure prophylaxis for an HIV exposure, indicating that they might be at elevated ongoing risk. If someone asks you for HIV testing, that may be a proxy for some of these other things. Has a partner who's positive, has multiple partners, or polyamory or non-monogamous relationships, sexual activity in an area of high prevalence or a network of high prevalence, has traded sex for goods or for money, the use of drugs, particularly in relation to sexual activity. All of these things are times when you should consider initiating. And these are basically CDC recommended risk behavior assessments for different categories of people. So the top is an assessment for men who have sex with men, and the middle is the assessment for heterosexual men and women, and the bottom is a risk behavior assessment for people who inject drugs. So that's a helpful tool. And then if someone has had a bacterial STI in the last 6 months, that is someone who should have PrEP considered for them. This is CDC and Preventative Health Services guidelines on prescribing PrEP and how best to do it. So the baseline testing does need to include a 4th-generation antigen antibody HIV test, which has a window period of about 10 days after acute infection to pick up HIV, and to screen and treat for any sexually transmitted infections, for hepatitis C, for sure for hepatitis B. It's extremely important to know whether someone has hepatitis B because both currently approved medicines for PrEP can fatally flare hepatitis B if suddenly discontinued. So if someone is testing negative for Hep B, they should be vaccinated. If they're positive, that needs to be a different treatment discussion. Creatinine clearance should be normal. People should have a pregnancy test to make sure that they're not pregnant. And you should not prescribe more than a 90-day supply. You do need to counsel on parallel risk reduction, and you do need to monitor closely HIV testing, risk assessment, adherence counseling, and sexually transmitted infection screens. The barriers to PrEP are multiple. Some of it is lack of awareness among providers. Some of it is lack of awareness among patients, low perception of their own risk. And then, there are individual costs. There are costs to payers. There's insurance lack, poverty, lack of access. Stigma is real, and stigma can kill. And stigma with PrEP is basically fear of being seen as taking something that confirms your promiscuity, or even might make people think you have HIV. Why are you taking these antiretrovirals if you don't have HIV? Sort of thinking. Prescribers may attribute stigma by having concerns that prescribing this may increase STIs or increase risk behaviors. Hepatitis B infection can be a barrier to PrEP. Adherence is an issue for healthy people who don't feel sick. Taking a pill that contains 2 antiretrovirals is a big step for a lot of people. And side effects do exist and can complicate treatment. And then there's mistrust of the system, structural barriers such as racism, and incarceration as well. The PrEP of the future is going to include modalities that do not require daily adherence. So a recent game changer was the HPTN 083 study, which confirmed superiority and efficacy of an injectable cabotegravir PrEP formulation. So that was injected every 8 weeks and had fewer HIV seroconversions than a group that took Truvada daily. It should be noted that this was largely attributable to imperfect adherence in the Truvada group. An injectable means you have slow-releasing concentrations of drug that protect you without you needing to do anything but return for your shot. There is a Merck product, islatravir, that is being studied and has good pharmacokinetic protective levels for up to a year, and a pill formulation that could be taken once a month. Obviously, we need to have TAF-FTC on the market for women and available to women. Microbicides are coming up. Raltegravir plus 3TC is going to be studied. So there's lots on the horizon, and looking out for the results of the HPTN 084 study, which basically is going to recapitulate the long-acting cabotegravir versus Truvada, but in women in Africa, will be key. So shifting gears a little bit to antiretrovirals, I wanted to talk a bit about guidelines and new and emerging therapies. So the indications for choosing a new regimen for HIV is obviously if someone has just been diagnosed and is treatment naive, if someone needs to be switched for either treatment failure due to resistance or adherence concerns, side effects, any sort of toxicities, people who are suppressed, but there's concern that they might have poor durability and might have viral emergence, and emerging availability of drugs that have higher potency, higher resistance barriers, et cetera. If someone gets put on a new medicine that does have a drug-drug interaction with a component of their regimen, that's a reason for a switch. If someone acquires a new comorbidity that needs its own treatment, that's a reason for a switch. And you consider many factors in constructing a regimen, and it should be infinitely individualized according to your individual patient's unique circumstance and needs, but these are all the things that you can take into account. So the Department of Health and Human Services has updated recommendations for the initiation of ART from December 2019, and it's a Class A1 recommendation that all persons with HIV be on antiretroviral therapy, both to reduce their own morbidity and mortality and to reduce the transmission of HIV to others. This should be initiated as soon as possible in order to increase uptake, increase linkage to care, decrease the amount of time people spend not suppressed. And when you're initiating it, you have to discuss with patients the benefits and talk about strategies that might work for them to optimize their engagement and their care and their adherence to these medicines. So ART must be given to all with HIV, but for some the urgency is increased. And these segments are people who are pregnant or have a high potential to become pregnant because there's concern about them passing HIV to their child. Those with AIDS-defining conditions, malignancies, dementia, et cetera. Those with acute opportunistic infections, with a few caveats that require HIV initiation to lag behind opportunistic infection treatment initiation. People whose kidneys have started to fail from HIV, that can be reversed, at least in part, with the initiation of therapy. Those who are in acute infection, you want to get them started particularly right away to decrease their size of their reservoir, and those with hepatitis B or C. So there's high market complexity now as compared to the days in which we only had AZT. We have 8 different classes of drugs. We have more than 40 products. We have many different new classes coming on the market. This is a slide about what to start. So these are recommended initial regimens for most people with HIV. And the basis for recommending them was durable efficacy to suppress viral load, pretty well tolerable, low toxicity, and ease of use, which often implies a single tablet. So first line would be an integrase plus 2 NRTIs. So bictegravir TAF FTC is a co-formulated single tablet regimen that is recommended. Dolutegravir abacavir 3TC is also a single tablet regimen that is first line if the HLA-B5701 test is negative. That is a test for abacavir hypersensitivity, which can be fatal. So if that test is positive, you would not start any sort of abacavir-containing regimen. There's also the option of doing a freestanding integrase inhibitor plus 2 NRTIs, and then an integrase inhibitor plus 1 NRTI, such as dolutegravir 3TC, that should say 3TC or FTC, except for individuals whose viral load is greater than 500,000 copies because of inadequate information on how they do with this two-drug therapy. So, if you have certain clinical situations, you might consider alternative regimens, and these are the regimens that you could consider depending on the particular clinical situation. But overall, based on characteristics of a patient prior to starting ART, if you had a CD4 count less than 200 cells per cubic millimeter, you would not use rilpivirine-based regimens. You would not use boosted PI or plus raltegravir, because those with low pretreatment CD4 counts do have a higher rate of virologic failure in that circumstance. Likewise, if your baseline RNA viral load is greater than 100,000 copies, you would stay away from selected regimens, including rilpivirine-based ones, abacavir 3TC with either efavirenz or boosted atazanavir, or boosted darunavir plus raltegravir, and that expands to dolutegravir 3TC is also one you would not use if your viral load is even above 500,000 copies. There's just limited data on how patients with those high viral loads would do on this dual therapy regimen, as mentioned. We discussed the HLA-B5701 being a contraindication to abacavir-containing regimens. And, do you have to wait for a genotype to start ART? You do not have to wait for a genotype to start ART, and in fact, you should not, because there's a recommendation for soonest possible initiation. And what that means is you should choose a regimen that's going to have a high barrier to resistance to start out with, and against which there's a low prevalence of transmitted resistance. So transmitted resistance to bictegravir, dolutegravir, darunavir is rare, and these drugs have very high resistance barriers, so these are regimens to consider. Also, you want to stay away from an abacavir-containing regimen initially because the B5701 results often are not available immediately. What I wanted to stress here is that people living with HIV, the majority of them are over 50 years old now. So it's important to note that not only those who already have HIV, but over 6,000 of the new infections occur in those greater than 50 years of age. And because HIV is often not suspected in those over 50 years of age, they are actually more likely to be at a late and advanced stage of HIV when they come to medical attention, when they're diagnosed. They can experience accelerated and accentuated aging due to the inflammatory effects of HIV on their immune system and their body, and they have an increased risk of side effects with age, as anyone in any population does. As people age, they're on more medicines, so there's a concern for more drug-drug interactions. There's cognitive decline, which has its own impact on the ability to adhere to daily meds in a fastidious way. And there can be stigma, isolation, a lack of social support that significantly adversely affect the ability to remain on ART. There's a very sensible approach modified from a geriatric approach that was pioneered by Miley Karras, which basically says that there's going to be comorbidities in people greater than 50 years of age. You should focus on treating those that are modifiable, that relate to someone's ability to move and to think, that are going to have high complexity, and that matter most to the patients. So there's not necessarily a need to put someone on 18 medicines for every comorbidity they have. There can be a prioritization scheme with the well-being of the patient at the forefront of your mind. It's important to note that multimorbidity, which is defined as having 2 or more comorbidities, does increase with age when people have HIV and when people don't have HIV. But at least 22% of people living with HIV have more than 2 comorbidities, according to the large NA Accord cohort data set. So I want to shift gears to talking about a segment of the population that also is disproportionately affected by HIV, and that's transgender individuals. So a 2016 survey from the Williams Institute found that 0.6% of U.S. adults identify as transgender. They have a almost 20% prevalence of HIV worldwide, partially due to social, cultural, and structural barriers that impact their ability to engage with care effectively. There can be lower viral suppression, increased morbidity due to all of these overlapping factors that conspire to keep them out of care, as well as adverse experiences when actually engaging with care. Many have challenges remaining on therapy continuously when they do have HIV, and remaining on PrEP when they do not have HIV. And approximately half of transgender people use gender-affirming hormone therapy, which can have some interactions with antiretroviral therapy. Moving on to other sets of guidelines, so the International Antiviral Society guidelines also list alphabetically bictegravir TAF FTC as a first-line treatment, dolutegravir bacavir 3TC, and dolutegravir plus TAF FTC, all as first-line regimens. So that you can see the emphasis on an integrase-based treatment. Shifting gears to new and emerging therapies. So several agents have been approved in the last 2 years. I just wanted to highlight the medicines that are single tablet regimens, so they're co-formulated standalone single tablet regimens. And that includes Biktarvy, that includes Simfy of both doses, that includes Delstrigo containing doravirine, Simtuza, which is a PI-based regimen with a pharmacologic booster, and actually dolutegravir 3TC, a standalone fixed-dose combination that does not require additional ART to keep people virologically suppressed. It's important to note that pill size can be a huge barrier for some people. Pill aversion and difficulty swallowing can definitely adversely impact someone's success on ART. Some of the smaller pill sizes here include Odefsey, Biktarvy, Delstrigo, but it's something to keep in mind that's quite meaningful and important to patients. Just to speak briefly about Bictegravir FTC TAF with the brand name Biktarvy. So this is containing a highly potent integrase strand transfer inhibitor. The trough concentrations that are established with clinical use are 20-fold higher than that required to suppress HIV. It is once daily. It doesn't require boosting, which can have drug-drug interactions. And it's been found to be non-inferior to dolutegravir containing regimens. And it can be active against many integrase strand transfer inhibitor resistant variants because it has quite a high affinity and a long dissociation constant. So it's got this high barrier to resistance that's an advantage. It does have metabolism through the CYP pathways in the liver, and so there can be some drug-drug interactions that are important to note. Moving on to doravirine, this is a new non-nucleoside reverse transcriptase inhibitor, which is on the market both as a single agent to add to other components of a complete regimen, or as a fixed-dose combination with TDF and FTC. So co-formulated with TDF FTC rather than TAF FTC is worth noting. It can be taken once daily with or without food, and it's treated for use in the antiretroviral naive or as a switch regimen for those who are stably suppressed, found to have equivalent efficacy to boosted PI plus 2 NRTIs in the Drive Ahead and Drive Forward trial. The Drive Ahead compared it to efavirenz-based regimens. There were less neuropsychiatric adverse effects than the efavirenz-based regimens and better lipid profiles than PI-based regimens. And then Drive Shift was their switch study, which showed that people who were virologically suppressed switched to this complete regimen of doravirine, TDF, FTC, did maintain their suppression with a high degree of durability and efficacy. Ibalizumab is of note because it's the first monoclonal antibody against HIV approved, and it blocks HIV entry into a cell by binding the CD4 receptor and inhibiting it from morphing itself and making conformational changes that enable HIV to enter the cell. It has orphan drug FDA approval for those with multi-class resistant HIV, and it's going to be active, unlike Maraviroc, which is active only against a virus that uses CCR5 as a co-receptor to enter the cell. It's active against both CCR5 and CCR4 tropic virus. It does have a long half-life. It's an IV infusion, which has its own pragmatic clinical challenges, and you administer it every 2 weeks after an initial load. But for people who are highly treatment experienced with few options, it can be a component of a successful regimen. Dolutegravir plus 3TC, as mentioned before, it is a standalone dual therapy regimen for people who have treatment-naive HIV, and can be a good regimen if you want a nucleoside-sparing regimen in people who have toxicities that make nucleosides problematic. So, also studied as a switch regimen. People maintain 97% virologic suppression at 48 weeks. This would not be an appropriate regimen for patients living with hepatitis B because 3TC is an ineffective and inappropriate option for treatment of hepatitis B. You need tenofovir, TAF, etc. Lower cost from two-drug regimens, lower cumulative lifetime drug exposures and toxicity are other considerations. Fostemsavir is the most recently approved antiretroviral. It was approved 2 months ago, July 2020. It's a first-in-class HIV attachment inhibitor. And it is a prodrug which gets hydrolyzed to its active form, and the active form of the drug binds to the envelope protein GP120 and blocks its conformational change and doesn't allow HIV to enter the cell. It should have full activity against resistant HIV strains. The approval is, again, for people with heavily treatment-experienced HIV and multi-class resistance. It is a BID drug. It should be taken with food, but basically, it helped people with multi-class resistance maintain a significantly greater decline in HIV viral load, and 60% on this regimen plus an optimized background regimen had undetectable viral loads at the end of treatment. The second study listed here is a phase 2B study comparing fostemsavir, TDF, and raltegravir in highly treatment-experienced people living with HIV who have failure on other ART regimens and showed favorable efficacy and safety at 24 weeks. And these are other new drugs, basically new co-formulations that enable lower pill burden. It's important to note that the drugs coming up in the pipeline on the horizon use many different mechanisms of action, and you can review those all here. But the new ART on the horizon really focuses on long-acting formulations. Long-acting cabotegravir and rilpivirine are approved for the treatment of HIV in Canada as Cabenuva. Islatravir is a highly potent NRTTI, as mentioned, extremely long intracellular half-life, and is being studied with doravirine as a dual therapy regimen. And lenacapavir, a capsid inhibitor that's highly potent, high resistance barrier, has potential applications for both PrEP and for treatment. So the real takeaways are that HIV is still prevalent in the U.S. New HIV infections are continuing to occur, even rising in some groups. Young men who have sex with men of color are disproportionately affected and bear an unacceptable burden of HIV. Guidelines are really emphasizing that all people with HIV should start ART as soon as possible, regardless of their counts or their viral load. And there's an emphasis in the guidelines on treatment regimens that include an integrase inhibitor and a focus on simplicity, tolerability, low toxicity, efficacy. There's an emphasis on duotherapy, new versions of familiar agents to improve pill burden, new classes of drugs, and the new agents likely to be approved in the next year or so include long-acting formulations of ART. Thank you very much for your attention and for listening. And now I'll turn it over to Jim, who will discuss managed care considerations. Thank you.
Thank you, Ethel, for the kind introduction. What I'm going to present is incorporating new therapies into the managed care formulary. Realistically, how does managed care view this space as it relates to, interacting with HIV products, patients, services? So if we look at the commercial drug trend for 2019, this is data from Express Scripts' annual drug trend report. HIV occupies the fourth slot, if you will, in terms of per member per year spend at $52.49. That's actually up from the previous year where it was in fifth place behind multiple sclerosis, but with the advent of PrEP as well as the single tablet regimens, we've seen it move up a little bit. And you can see here in terms of utilization about 3.5% trend and total trend overall about 8.1%. So a significant budget impact for plans as a category of drug and disease. This slide looks at the top classes for commercial plans by spend. And here what we're seeing is that traditional generic drugs in the light blue, traditional brands in the darker blue, and then specialty generic light orange and specialty brand in the dark orange. And you can see here with the HIV category, it's essentially all bright orange, meaning that plans view these as specialty brands. We do have some generics that have launched, but in general, it's still predominantly a branded class, which is why it sits up quite high on that overall commercial drug trend slide. If we look at growth in this space, this is some projections from IQVIA data. We see in 2018, the HIV spend was about 9%. We see that in the lighter green bar here. And the contribution to growth expectation for 2019 to 23, based on IQVIA estimates, is about 10%. And projected spending out to 2023 still has it sitting around 9%. So not a category where we're expecting significant growth per se. It looks to be a little bit constant. We are seeing a little bit of growth in oncology, as well as autoimmune disease and immunology, just slight increases. But again, it's going to maintain itself as a steady product category with significant budgetary impact. If we look at the treatment landscape, this is just sort of a trip down memory lane here. If we look back to 1996, the average life expectancy of 39 years, majority of patients were less than 50 years old, and the daily pill burden was 21. So from a pharmacy and a plan perspective today, we're at well over 50% over 50 years, as Ethel indicated earlier. And the life expectancy has also increased, as she mentioned, and what that leads to is the comorbid conditions now presenting as challenges and opportunities, if you will, in this category of patients. So we have to manage current and future comorbidities, as well as making sure as we select ARV regimens that we maintain adherence, compliance, and minimize drug interactions, and certainly a challenge. But the daily pill burden, of course, is averaging 1 with a lot of these single tablet regimens, which is quite phenomenal. And from a formulary management perspective, anytime you can reduce the pill burden for a patient, particularly from a high number of doses to a single tablet is always viewed favorably, and it drives improved adherence. If we look at the entry of new HIV medications in the United States, as you can see here, and again, this was referenced earlier as well, the number of different categories of drug from a scientific perspective that have been brought to market, and as was indicated, there are more coming. So as we see here, the timeline of FDA-approved drugs over this 35-year period has been quite significant, from Zidovidine in the early mid to early 80s, and now, of course, with the latest products in the last couple of years, and a number of products coming as well. So clearly, the marketplace has changed dramatically, and what we see with the sales of products, if you will, and this is a projection that takes us from 2017, some actual numbers through 2027, the single tablet regimens obviously are going to be dominant in the marketplace, which makes perfect sense because these are the therapies that are going to be driving good adherence, easiest to take, and as we improve on the combinations and the safety and tolerability and side effect risk of the elements within these, so the components, we see some great opportunities to drive effective outcomes by choosing the therapies that are better fit to the marketplace and the patients. Here we see in the PrEP category, we've seen a dramatic shift, which started in about 2017 from the TDF regimen to the TAF regimens. As was mentioned, we see an opportunity here to have less bone and renal effects with the TDF regimens, and clearly the marketplace has responded and the providers have responded dramatically to this. Now, we will have a generic TAF regimen for PrEP that's going to be launching in the not-too-distant future, but clearly if the market has flipped, we're not going to see necessarily any efforts or push, if you will, from plans to try to move patients back to a generic. Often in a category like this, where there is a lot of competition, you may see a preferred product being used, and once a generic is launched, because the price differential is significant, plans may try to push patients back to the generic if they were on a different therapy, a new branded therapy. But in this case, I think given the clinical differences and the uptake by providers, that's less likely to happen. Now, there may be individual patients from a cost perspective or an out-of-pocket perspective who may need to choose a generic option that may be in a lower copay tier or coinsurance tier, and that's something the physician has to have a conversation with the patient about. If they have low risk, if you will, for some of the safety and tolerability issues associated with a generic, they may be comfortable prescribing that to that individual patient. And we see that a lot in the Medicare space, not necessarily with HIV, obviously, but where you'll see Medicare patients who have some out-of-pocket challenges, and the providers will work with them to try to find a less expensive generic option while still minimizing sort of issues of safety and tolerability. So some of the issues with this space, if you will, from a plan perspective, it's still primarily a hands-off category, and by that I mean there's not a lot of aggressive utilization management that's in place. It is high cost, as we mentioned, number 4 on the tier of spend, but relatively low utilization, and by that I mean when we think about categories like diabetes and autoimmune and other categories where we have significant volume of utilization, asthma, COPD, cardiovascular disease, these are ones that there's much greater utilization, obviously, from a broader perspective and a lot more focus on those. Many of these drugs are on a preferred branded tier, although the majority, a preferred specialty, if you will, and in some cases non-preferred specialty. There's typically not a lot of contracting that's going on, and a few preferred agents, and why I have that here, what I mean there is in terms of trying to drive patients to a particular product. When you have a product that's being given to a patient and the patient has adequate viral suppression, you're not going to have plans saying we want to forcibly move a patient off a drug that's working and put them onto another drug because it's less expensive or we have a contract. And that's another reason we don't see a lot of aggressive contracting in this space, because once a patient gets on a regimen, is virally suppressed, there's no reason to disrupt that and try to change the patient. And we saw that certainly with hepatitis C. We got patients on that regimen. We wanted to make sure they got their 12 weeks of treatment, we could get a cure and move on. So certainly the new branded drugs, the combinations have had a dramatic impact, as was demonstrated on the earlier slide with the single tablet regimens, and the DHH recommendations of 5 or 6 approved treatment options. So the providers and patients have a lot of opportunity to come up with the right mix of product, if you will, in that single tablet regimen or in that PrEP combo to effectively treat them. As I mentioned, generics have launched. One question that comes up from time to time is, do we expect plans to break apart a product that's in combination when one of the elements may be generic? And again, not typically something you would expect to see in the HIV space. And for my earlier comment on once somebody is effectively being treated and virally suppressed, you don't want to disrupt that. You don't want to take them from a single tablet and now they've got to go to a 2-tablet regimen or perhaps a single and a twice-a-day regimen. So not likely we would see that. Again, a physician and patient could work together from a financial perspective if that was appropriate for a patient because they couldn't afford some of the higher copays of products. That is a possibility, but again, not likely a good strategy here. And non-single tablet regimen products are used in combination, and price is considered when compared And again, the out-of-pocket cost for the patient is clearly something that comes up in conversation. Let's move on to adherence. So if we think about non-adherence and treatment failure predictors, the PEARL study looked at the efficacy and safety of 3 antiretroviral regimens for the initial treatment of HIV, and it was a randomized clinical trial, well documented and well studied, and the results were not terribly surprising. Once daily regimens had a lower non-adherence rate than twice daily regimens, and it did attenuate over time. I think from a plan perspective, plans are generally comfortable with a BID versus a once a day. There's not necessarily broadly a concern that you have to cover every once daily regimen if there are twice daily regimens that are equally effective. And we see that in other categories as well. But clearly in an area like HIV, when you want to have good adherence and viral suppression, a once daily regimen is always going to be preferred. Some of the issues they found in this PEARL study that were related to non-adherence, hard drug and soft drug use, unprotected sex, worse health status or quality of life, and younger age groups. So again, signals for practitioners to look for as part of that sort of patient history and conversation as to, is my patient at risk for adherence challenges, and what can we do to try to improve that? There's a number of strategies that can be employed to improve adherence. Certainly, patient education is number one here, and we have a number of partners, if you will, out in the marketplace from a plan perspective who can help us. That can be the retail pharmacy. It can also be the specialty pharmacy. Certainly, the specialty pharmacies are well known for much better adherence with therapies than the retail sector in general, but part of that is just simply the fact that they outreach to patients every 3 weeks. As part of their business model, they ship the product. It's a 30-day fill cycle, and then at approximately 21 days or so, they're calling the patient, outreach, check on them, how are you doing, are you ready for a refill, how many doses do you have left, and ideally they're managing that patient's refill status, and at least it's an interaction, an opportunity for that specialty pharmacist who often is skilled in the HIV space to engage and entertain any questions, concerns, problems a patient might have. Now, at the retail sector, we have these auto refill programs, which arguably get the patient an automatic refill, but may not necessarily yield a good interaction. So you could have a patient who auto fills and gets the prescription, but doesn't necessarily take it in an adherent way. There are certainly pay-for-performance programs you can establish as a plan with the specialty pharmacy to pay a special rate, if you will, or a performance bonus if they're successful at driving compliance or adherence to therapy. We also can strengthen patient-provider relationships at the outpatient level to improve compliance, empowering the patients, encouraging them to be compliant with therapy. We can integrate communication channels, which I'll talk about in a minute. And I think a new area where there's a lot of interest and excitement is digital applications, things like medication reminders, smartphone applications. They also have a number of products that can be used that are very unique. They have pill bottles, for example, that actually track the weight of the capsules or tablets in the bottle. And as the patient takes a dose out, it records that, and you can determine at least the patient took a dose out of the bottle. Now, it doesn't mean they took it, but nonetheless, there are all these really creative ways to try to remind them. They also have pill bottles with reminders and lights and bells and whistles, and so to speak. So again, I mean, a provider can work with a patient, try to find one of these applications if it's needed. If the patient has cognitive challenges and needs to be reminded to take their medication, certainly a way to do that. So some of the patient empowerment strategies, really one of the key thoughts here is, and this is from Butterworth in the Journal of Managed Care Pharmacy, is well-informed advice, well-intentioned advice, and not scare tactics. Obviously, prompts patients to adhere more effectively. You don't want to scare patients. You really want to encourage them to be empowered to take action on their own, to manage their own disease state, manage their own medication adherence. And there's a lot of complex motivations that can be at play here. And again, some of this comes up in that interchange with the provider and the patient, in that taking that patient history or just engaging in a conversation, or perhaps using ancillary staff in the office to interact. And the pharmacy can do this as well, and specialty pharmacy has various scripts that they can actually employ on behalf of plans. So when they do call the patient at that 3-week mark, they could actually go through a series of questions with the patient just to see how they're doing. But things like perception of benefits, their expectations. I think you may have a patient who says, when I take this PrEP, or if I take this drug for treatment, I'm getting a cure. And you have to manage that expectation that at this point there is not a cure available, but these are products that are going to effectively manage the disease and prevent spread of infection. So again, managing that, patients' ambivalence perhaps, their readiness to change certainly is another one. So there's a number of these that certainly can have an impact on the patient's ability to comply with therapy. Certainly considering social determinants of health is another one that's important, and something that a lot of plans are integrating. And we see a lot of programs and services now around this, and some of the pharmacy educational programs that I've participated in have addressed this very specifically to engage the pharmacist in appreciating and understanding where social determinants of health factor into a patient's ability to comply with therapy. The integrated communication channels, we have a multi-provider level communication option here, and obviously we have to get everybody involved: physicians, pharmacists, nurses, case managers, and providers have to communicate, respect for the patient's perspective and condition, which certainly they would always follow that rule, if you will, provide a rationale for their treatment, negotiate this plan, the anticipated problems that may occur, safety, tolerability issues, help them manage that. And again, the pharmacies can play a role there in guiding the patient through that challenge of taking on a new drug and not necessarily appreciating the safety and tolerability issues that may come along with that, and get a collaborative process for problem solving. And if the specialty pharmacy identifies a problem, they should be reaching out to the case manager or the provider to make them aware of a potential problem that needs to be addressed. Specialty pharmacy is another category here that's important, which we've covered in great detail. But keeping in mind, case management can also work in an interactive way from a plan perspective with specialty. The support programs and outreach that I mentioned, and compliance monitoring is another area of opportunity that we see great assistance and provision of by the specialty pharmacies. Some of the strategies employed by specialty that the plans find particularly beneficial, and this is broadly across all disease areas, certainly benefit management, helping us develop that multi-specialty formulary, applying the utilization management that may be in place. So there could be some prior auths on drugs in this category. Again, not necessarily terribly restrictive, but ideally you want to manage the utilization to the appropriate population. That's the design there, so we're not getting a lot of off-label or inappropriate use. Cross-benefit management is a new strategy, and as Ethel mentioned, we've got this injectable product coming that may compete. So there could be plans that feel that they are comfortable with an oral versus an injectable. There could be some cross-benefit requirements that the patient has to demonstrate compliance on an oral before maybe they'd be eligible for an injectable, vice versa. Again, not clear that will happen, but the opportunity does exist, and that a procedure, if you will, is used pretty regularly in the marketplace today in a number of various disease states. Medication therapy management certainly becomes more complex and challenging as these patients age and develop more comorbid conditions such as diabetes or heart disease. And contracting, as I mentioned, very commonly used in specialty pharmacy, but not employed in an aggressive way in the HIV space. As far as management goes, I mentioned the medication therapy management and all the commensurate tools and resources that can be applied to help that patient, because the plans don't typically have the resources internally to manage these patients. They really need to effectively get assistance from specialty to do that. And we can design programs, workflows, analyze utilization, and again, they're going to have trained personnel, specifically experts in HIV. As far as the patient out-of-pocket issue, and we look at the multi-tier structure and design here of benefits, you can theoretically have any of these drugs could fall in any one of the tiers, although typically we would see these drugs in tiers 3, 4, 5, the higher tiers, where copays can range from $30 to over $100, and coinsurance can also play a factor here where patients could pay a coinsurance. And you see in the bottom of this slide, the typical cost shares represent about 19 to 25% of the total cost, and copays range from 5 to 90 plus, and coinsurance range from 10 to 50%. So if you have a patient in a health exchange product, they very well have a 50% coinsurance. That could be a barrier to access for some of these newer agents that cost $3,000 a month. If they've got to come up with $1,500 out of pocket, that's not likely going to happen. So the key takeaways: HIV has been pretty much a hands-off category. It will likely change somewhat with generics, more costs, additional tablet regimens, injectable, medical versions. Adherence will continue to be an issue. Clinical management can be better if we use an integrated approach and specialty medication therapy management, and all stakeholders need to be involved: patients, providers, payer, and the pharmaceutical companies. And final thoughts here, with new drugs coming to market, cost containment is going to be an issue. If it represents 9% of the spend in specialty, plans are certainly not going to ignore this as a space. Many of these products have been developed with safer profiles, which certainly benefits patients over time. The favorable safety profile of TAF-FTC in particular has been reflected in the evolving IAS and DHHS guidelines. There's an emphasis on simple single-tablet regimens, or at least once daily dose, is reflected in the guidelines. And starting and keeping patients on highly efficacious, well-tolerated regimens with minimal toxicity is critical for long-term compliance, which subsequently benefits the long-term health of people living with HIV, who can now expect a close to normal life expectancy. Regardless, all members of the healthcare team must work together with patients to improve compliance and drive optimal outcomes. Thank you very much.
Okay, now it's time for our question and answer section of the program. And we do have one question that's come in, and I'm going to address this to Dr. Weld. For what patients and for what indication is TAF-FTC approved for PrEP?
Yeah, thanks, Jim. So that's it's a topic of some confusion sometimes, because the labeled indication of TAF-FTC for PrEP is that it's indicated in adults and adolescents who are at risk to reduce the risk of HIV infection from sexual acquisition, but it excludes those individuals who are at risk of HIV from receptive vaginal sex. So this is really not because there's any physiologic reason why it wouldn't necessarily work just as well in women. It's just simply because effectiveness in women has not been evaluated. So women were not included in the large trials that proved the effectiveness of Descovy or TAF-FTC as a means of PrEP. The company that produces it has committed to pursuing trials with women, but that data is forthcoming and not yet available. But in the meantime, it's extremely important to note that Truvada, or TDF-FTC, is approved as PrEP for women and men. So there's a safe and effective option for women, just not TAF-FTC at this point per the label.
Great, thank you very much. And believe it or not, that's the only question we had that came in today. So we've reached the conclusion of the program, and you will be redirected back to the landing page to complete the evaluation if you haven't already. And you can download and print your certification right away. And I want to thank everyone for attending. Thank Dr. Weld also for a great presentation, and I wish everyone a safe and healthy rest of the week. Take care now.
Thanks so much, Jim. Thanks, everyone.